this one.
I'd like to invite Dr. U. Srinivasa Rao sir, the military surgeon, to occupy the chair as the chairperson for this session, sir.
A condition which is associated with chronic anovulation. So this is the condition where you really need to do your ovulation induction, not so in so many other conditions like unexplained infertility, male infertility. You trying to manage the ovulation induction is not going to help. But this particular group of patients, or PCOS patients, definitely needs a good induction protocol for her to form eggs and ovulate. And remember, it is only a functional derangement. It is not a peripheral or a central defect. And it develops when there is a chronic anovulatory state which is there for a very, very long period of time. Treatments in PCOS, first is always lifestyle intervention. Next are the drugs. That will be letrozole, clomiphene. You combine clomiphene with metformin. Metformin alone, or last will be gonadotropins. I'm not going to touch on everything. Mostly the drugs are the ones I'm going to concentrate on. But I'll be talking on gonadotropins and ovarian drilling as a part of ovulation induction, as well as the third line therapy, which is IVF and in vitro maturation. So when you want to talk about clomiphene citrate, remember it's the first orally active agent which has been used for ovulation induction. It is a SERM, the selective estrogen receptor modulator. You give it a dose of 15 mg per day and you start at day 2 to 5. And suppose you do not document an ovulation, you will increase the dose. Maximum you can go up to is 150 mg. And suppose you document ovulation according to ASRM, you can give her 6 cycles of ovulation induction, hoping that she will become pregnant. And you will have a 60 to 85% ovulation rate and a pregnancy rate of 40 to 50%. Remember that not all patients, just because they are ovulating, will become pregnant when they are on clomiphene. So the next drug which came into the picture was in 2000s, and that was the aromatase inhibitor letrozole, which is an alternative ovulation induction drug. And this works by conversion of androgens to estrogens. I'm sorry, by inhibiting the conversion of androgens to estrogens, and that's why you have a hypoestrogenic environment, and that's why she starts producing FSH. And it will have the advantage of not interfering with the endometrial development, which can happen with clomiphene, and it can be very useful for an obese patient who is not ovulating with clomiphene citrate. The advantage will be it's a monofollicular development. You will not have those multiple follicles and OHs which can happen with the gonadotropins. And now letrozole is the first line therapy. We were using it under the table earlier. 10 years back, we used to say take letrozole, but we never used to write on a prescription. But now you can write it. And the dose is 2.5 to 5 mg per day from day 2 to day 6. And what is the advantage of letrozole over clomiphene citrate? The resistance is lower. The patient has got a higher birth rate of 40 to 60%, and importantly, it forms a monofollicular development, so multiple pregnancy is much lesser, and the incidence of hot flusher is lesser. And traditionally, that 5 days is just arbitrary. Nobody knows why that 5 days has come into the picture, but it is quite effective. So they have continued with that 5 days dosage. And you have to know what is resistance. The patient is failing to ovulate even at a dose of 150 mg of clomiphene or 5 mg of letrozole, in spite of increasing the dose for the next 3 cycles. And it occurs in approximately 15 to 40%. It's a big number who will have resistance to letrozole or clomiphene. Failure is she has ovulated, but she fails to conceive. So next line of therapy is gonadotropins, and it is actually used when there's a failure of pregnancy with your ovulation induction with your oral drugs. And it's a second line therapy because it's the cost is too much. When you start giving gonadotropins, there's a potential risk of multiple pregnancy, and ultrasound monitoring is necessary, which is not so with the oral drug. And the ASR guidance on gonadotropin therapy for PCOS is you will start at a very low dose, and that's 37.5 to 75, and you have to give that for 7 days, then check her follicular size. Still if she's not responding, then you will increase the dose of gonadotropins. And to make it easier, now the pen devices has come and the patient can use it much better. And always you have to start the next dose when you know that what dose she is responding to. And remember, there's no difference between urinary or recombinant, just the cost is the problem. And always go for agonist trigger and give a good luteal phase support if you've got multiple follicles, because that will avoid OHSS. And the disadvantage will be the cost, the multifollicular development, which leads to multiple pregnancy, OHSS, and and sometimes you need to shift from regular follicular stimulation having a timed intercourse, you have to shift her to a IVF cycle. And so that's why there are some alternative regimes which have come. These are very, very useful for those resistant patients, and that is you give clomiphene or letrozole for an extended duration of time instead of 5 days. You give it at increased dose. Go for stair-stepping, that you give a dose, not responding, increase the dose, again wait for 7 days, again increase. That is the stair-step protocol. You can combine these drugs. Even you combine letrozole, clomiphene, and you're finding good results. And the last will be the sequential regime. And the extended day regime is, even in the 1982 there was a study which said when you give it for a longer period of time, ovulation induction drugs work. And that's why you can give your letrozole for 8 days rather than the 5 days when they do not respond. And regarding for the extended regimes, remember when you give clomiphene for that extended regime, there's a higher chance of multiple follicle. But with the letrozole you may not have, and that's why letrozole is much better when you go for an extended regime compared to the shorter regular regimes. And there's no anti-estrogenic effect of letrozole on the endometrium which can happen with clomiphene when you give for those extended regimes. And that's why when you choose a drug to go for extended regimes for a resistant patient, you do not want to use gonadotropins, letrozole being given for a longer period of time is much more effective. And these are the regimes which is used in the study. This is a regular one, the group 1, 2.5 or 5 days. Second group was 2.5 for 10 days. Third group was increasing to 5 mg for 5 days, and the last was 5 mg for 10 days. And in the groups 2 to 4, there was no increase in multifollicular development, but they had a good pregnancy rate. So all these last 3 regimes actually quite good enough for a patient who is resistant to a regular dose of clomiphene or letrozole. And the studies in 2024, they said a 5 mg dose or an extended 10-day dose is actually good. It is not bad as it was thought before. And prolonged letrozole therapy, they used it for a very, very long period of time also. This they have a good response. And that is the stair-step protocol which everybody needs to know, because the cost of gonadotropins is reduced when you give these drugs for a longer period of time. So you start at letrozole of 2.5 mg for 5 days and wait for a week. Do a scan. The follicle is not growing beyond 10 mm. Again give a dose which can be 5 mg, 5 days, wait for 1 week, then do the scan, no follicle, increase it to 7.5. That is a stair step. Stepwise you are increasing the dose to see the response, and it works really well in a group of patients who are resistant to the regular dose of letrozole. And this is stair step as efficacious as clomiphene, which is also used as a stair step protocol. And the sequential therapy is you give clomiphene and then add gonadotropins if he is not responding. And sequential therapy you can give letrozole and then add HMG, which will also have a good result compared to giving simply HMG, which may be very, very costly. These are the combination protocols. You can combine clomiphene with gonadotropin, letrozole with gonadotropin, or even clomiphene with letrozole. There is a person in Tamil Nadu who is doing a study on giving clomiphene not working, and she's added letrozole. She's giving a group of 40 persons, and she's saying 40 patients she's given, and she says it gives a very good response. And this is the way you give the combination protocols, where you give again you give letrozole with gonadotropin. It's not after that. It's not sequential. You combine both at the same point in time. And you can combine clomiphene with letrozole. As I said, there's a study in fertility stability which says it actually works. And protocols to reduce premature LH surge, which can happen even in your IUI cycles. You can give clomiphene or letrozole for a long period of time. It will suppress the production of LH from the pituitary. So you will, when you are inducing or you are triggering her, you will actually have a good ache. And luteal support is always a must when you are giving gonadotropins for your stimulation. Other option is ovarian drilling. Ovarian drilling will be a second-line therapy. It's very good for a young patient, a thin patient, and has got a short period of infertility. It's very good for that group of patients. And there was a study in 2019 which was done where they compared drilling with drugs, and they said it is actually 2.27 times better when you do a drilling for a correct, appropriate, selected patient, which gives a good result. IVF will be the last resort in PCOS, and when you do IVF for a patient with PCOS, do not go for that long agonist protocol. The antagonist protocol is the best, and always you should not give HCG for the trigger. It should be the agonist trigger, because that will prevent OHSS. and you will freeze all your embryos. You will not transfer in that cycle because that is going to increase the chance of OHSS. And some have added metformin, thinking when you do an ovulation induction for a PCOS patient and she is going for an IVF, metformin can reduce the chances of OHSS. And another therapy which is available is being done in Bangalore is IVF, in vitro maturation. You pick up those eggs very early, do not allow them to go beyond 14 mm, take that, allow them to grow in the lab, you will do an ICSI for them, freeze those embryos and transfer in the next cycle, not in that cycle because the luteal phase will be deficient for them. And so there are some burning questions in resistant PCOS when you are doing ovulation induction. When you add metformin, does it actually improve the results? And what after clomiphene, letrozole, gonadotropins, you have tried everything, still the patient is not responding. Does ovulation in a PCOS patient actually guarantee a pregnancy? Will addition of IUI help, or is IVF the answer for all your PCOS patients who are not responding to your therapy? And please remember that metformin addition is not superior at all. It's been proved by so many studies now. And this was a big study which compared the cost of therapy for a resistant PCOS patient who is not responding to a conventional therapy. And the best thing which worked was give her clomiphene or letrozole for at least 6 cycles. Next 12 cycles, add gonadotropins. 16 cycles not responding, then go for 3 cycles of IVF. That seems to be the most cost-effective approach. And that was a study in 2014 by Moliner. And he said, actually the birth rate of 58% suggests that we need more than IVF. It is not IVF which is the therapy for PCOS patient. And will ovulation assure a pregnancy in PCOS? No. There is factors which we don't know. There may be a negative effect of the unopposed estrogen at the level of the endometrium and cervical mucus. So will adding an IUI then help? And that is also not so useful. Remember, it is more than ovulation induction in PCOS. There is also the inflammation which is there, the insulin resistance which is there, the obesity which is there, which is all adding on to the negative reports in PCOS patients as far as ovulation induction is concerned. So please ask her to optimize her health status which is not responding to the conventional therapy before you go on to higher modes of treatment like IVF. And vitamin deficiency and ovulation induction, it is not associated. Do not wait for her to correct her vitamin D levels before you start ovulation induction. Same thing, there was a study called the Pregnancy in Polycystic Ovarian Syndrome in 2024, April it was published. There they said when the AMH level is very high for a lady and you want to stimulate her, induce her for ovulation, remember you will have poorer results. And that's why AMH has to be brought on with lifestyle changes, diet, exercise and all that before you can move on to inducing her with ovulatory drugs. So the take-home message is letrozole is preferred at this point of time. Starting dose is 2.5 milligram, but if you do not have a response, move on to a higher dose or an extended duration of therapy. Remember, there's a good therapy in the form of a redosing or a standstill protocol which works with the letrozole. Ovulation will not guarantee a pregnancy in PCOS. IUI and IVF do not give better results in PCOS. It's the ovulation induction and the lifestyle changes which the patient makes. And remember to always induce very, very carefully in an IVF patient ovulation induction PCOS because OHSS will be a big complication. And always remember to use an antagonist protocol with freezole and adjuvants like metformin and vitamin D are quite of doubtful value. Thank you so much, Dr. Radha Lakshmi, Dr. Venkat Raman and Kapul Society. Thank you.